InsideVision is brought to you by New England College of Optometry and Sector Media Group.
Hello, everyone, and welcome to Inside Vision, Episode 4, Will Managed Care Rescue the ECP? Great to see everybody again. Thanks for joining us. We have a really great show for you again. Happy to welcome two fantastic guests who bring so much insight to the subject of managed and vision healthcare. That's Jim McGran. Many of you know Jim from his time as CEO of VSP. Today, he is the Chairman and CEO of Healthy Eyes Advantage. And if you've not heard of Healthy Eyes Advantage, you need to hear about it. It's a great resource for practitioners, and we'll hear a little bit more from Jim about that today. So we're thrilled to have Jim McGran with us. Also joining us today is John Ryan. John is the General Manager of United Healthcare Vision. John has over 30 years of experience in healthcare. So two fantastic people, Eric, this morning are going to bring us some great information, but we're happy to welcome Eric from out there in the field, Valdosta, Georgia. How's it going out there, Eric?
Yeah, it's going well. We're in the heart of South Georgia here, and it's really the leading edge of optometric reopening. I'm at a practice that last year on this day did 193 patient exams and services. Yesterday they did 51, and I think today have about 34 patients. So it's kind of a barometer that we can look to see what does reopening look like. This has been and will be again a thriving practice, but they're down from 5 doctors to 2. They're down from staff from about 51 to 12 or 13. So things are slowing down. People are coming back. It's slowed down from before, but people are coming back in small waves.
I mean, that's a good sign, absolutely. And I think we're seeing that around the country now as so many practices, if they're not starting to be back, they're certainly doing the final planning for being back. And it's interesting to see over your shoulder there, looks like a little white tent outside. They're doing some screening. Can you tell us a little bit about what's going on there?
Yeah, it's really interesting to see, because for everybody out there that wants to know what reopening looks like, what it looks like here is patients waiting in cars in the parking lot, then approaching a tent to have their temperature taken. They're masked. They're given a mask if they don't have one, and then they're taken through the process in such a way that spatial distancing is obviously of the utmost importance. So they're doing exams. They're retailing glasses. Tonight, we're going to have a full report from this location. We'll be posting that to the InsideVision channel sometime this evening. And if you'd like to see that, go ahead and click the subscribe button on the YouTube channel, and you'll get a notification about that. I think a lot of people will be interested to see exactly what this looks like down here.
Thanks, Eric. I think a lot of the issue here is, will patients feel comfortable coming back? I think practitioners are going to do everything they can to create a safe environment. There's no guarantees, of course, but I know they're doing everything they can. Have you had a chance to get any sense for the patients? Are they nervous about it? Are they positive? Are they ready to roll? And then, is this pent-up demand we're hearing about? What do you think about that? And I'm interested in hearing from our guests on that one too. But what have you seen since you've been there?
There's certainly pent-up demand. They had to drop some of their phone lines here because they were operating 12 phone lines, had to drop down to 5, start sending patients to voicemail with a custom message that says, we'll get back to you later on, we're here for you. But they're also communicating through Facebook and social media, different modalities like that. But there is certainly a pent-up demand, and there's also a portion of the patients who are very concerned, who are really afraid to come in. So when you have a patient that's afraid to come in but really does need to come in, the staff here is working hard to make them comfortable and also take care of their needs. So to answer your question, it's a wide variety, and the manager here told me that it's kind of like always. Some patients have particular needs, others are for others it's just a normal day, and I have to say that down here in Georgia, having come down from New Jersey, the difference is striking. Driving down Interstate 95 for the last couple of days and stopping along the way in Ashland, Virginia, and Savannah, Georgia, the further south you come on that journey along the East Coast anyway, the less it feels like COVID-19 is on. I mean, everybody here, and these are patients rolling into the parking lot here now. There'll be some patient flow throughout this hour for sure. But as you come south, it just becomes apparent that there's a different mentality than there is in the Northeast, where I have been for the last 6 weeks or so. And it's interesting to see that where the care is being taken here to keep everyone safe, a couple blocks away, last night, I could see hundreds of people inside a bar, none of them wearing masks, and people operating and celebrating Cinco de Mayo in a way that it would have looked like last year.
Well, I mean, we're seeing that all over the country. There's certainly a difference. Some states, some cities, some towns are in a different place than others. But, you know, the boundaries, the artificial boundaries we draw between states don't do us much good. A virus doesn't know those boundaries. But you be safe out there. And, you know, I think it reminds me, Eric, that, you know, you said it, and it's become a bit cliche, unfortunately, but we are all on this together. And at a time like this is where we need our partners. This is where partnerships are so important. And, you know, there's been this historic kind of friction between managed and vision care payers and providers. And I think that's just naturally the case. And, you know, it just inherently is going to happen. But I tell you, I mean, I meet some of these quality people who are running these organizations, two of them on our show today. These are people really trying to do the right thing. These are people who really do care. And to me, it's times like this where these partnerships are just critically important. So Eric, if you're okay, we're going to bring on our guests, Jim and John, and ask them a little bit about their perspective on things. But thank you for being out there in the field. Stay with us. I know you're going to continue to give us some ideas of what's going on there. But another welcome back to Jim and John. Thank you guys for joining us. Appreciate it. Hope your families are well and you guys are doing okay. And thanks a lot for being with us this morning and sharing some of your thoughts. And Jim, if you don't mind, we'll kind of kick it off with you, and I'll be pretty broad as my starting point. You have such a great insight into this industry and the different roles that you've played. You know, how are you, or what advice might you have, I guess, for dealing with challenging times, challenging issues that we're all facing? Eric outlined some of the challenges we face with patient flow, et cetera. Perhaps you could get us started with just some general thoughts, if you don't mind.
Sure, happy to, Howard. Thanks so much for having me. Eric, thanks for being there on the front line, you know, because when you look at this situation, right, eye care professionals are the heart and soul of our industry. If you take a look at Jobson's research this week on the independent side, 93% of practices are saying they plan to reopen, which is great for the industry, and Eric's sitting there in front of one of them. The only however I put to it is that only 68% of them said they've developed a written plan on how to reopen. And I think that really is a critical first step, you know, along with fully understanding their economics and the fact that cash is king. You know, again, you heard what Eric said about the patient flow last year versus patient flow this year. How do you manage that cash? And the eye care professional is really the CEO of their practice. And one of my favorite articles in Harvard Business Review talked about the 4 most important characteristics of a CEO. They have to be decisive. And these guys are making tons of decisions right now, trying to figure out how do we open, how do we handle our patients. They have to be enabling. That meaning enabling their employees, enabling their customers to be successful. They have to be adaptable. As they open, they're going to learn new things. The world's going to change. Does a spot heat up? Do they have to back off? Do they have to go forward? Have to be adaptable. And then obviously they have to deliver results. So the good news is that they don't have to do it alone. You know, every company in the industry is putting together tools and offerings to assist with the reopening. At Healthy Eyes Advantage, we've developed a recovery reboot program. Dr. Justin Manning is leading that for us. It has downloadable checklists that walk the practice through how to reopen. And these checklists take advantage not only of Healthy Eyes Advantage, but the 250 strategic vendor partners we have and all of the hard work they've done to help practices reopen. So the big point is you cannot and should not go through this alone, and you don't have to. No one person, no one company has all the answers. So they should take advantage of what they have. And you asked about what we're working on, and John and I are working on something together, and then I'll toss over to him. But one of my favorite books is a book called Team of Teams, New Rules of Engagement in a Complex World. And in that book, General Stanley McChrystal discusses that when he took over as the commander of American coalition forces in Afghanistan, what he had to do, and this is his quote, right? Tear down familiar organizational structures and rebuild them along completely different lines, swapping their sturdy architecture for organic fluidity, because it was the only way to confront a rising tide of complex threats. This war was not a war of planning and discipline. It was one of agility and innovation. What we are in here in our industry is really a war of survival, especially for eye care professionals, and I might say independent eye care professionals. And we as an industry need to be laser beam focused on helping them survive and thrive. One more quick thing, a good example of why they have to survive and thrive. I saw a statistic this week in 2017, doctors of optometry diagnosed 401,000 patients with diabetic retinopathy who did not know they had diabetes. So if they're not getting in the practices and not seeing the doctor, their diabetes is going to progress. So the project John and I are working on, along with other industry CEOs and the Vision Council, we want to provide clear and actionable insights, information, best practices, protocols, and tips. We want to make it easy to find, easy to use, and it's a real how-to of how do we get open and how do we restart. So John and I have spent some time leading up to this. We both have a like of the team of team models, and we've both had the pleasure of meeting General McChrystal. And I know John has a lot to offer on this subject as well.
Yeah, we're going to throw it to John. So thank you, though, for that great bits of information that are very useful. I think, part of the issue I see, and a positive one, is as optometry in many states has been identified as essential care providers, I think in the end, this goes a long way to helping to continue to proliferate the things that you talked about, diabetic diagnosis. I know 70% of the eye exams are being done by optometrists, primary care eye exams. They're seeing a lot of these things. And I think I'd love both of you. We're going to throw it to John, but I'd love both of you to talk about, what you're working on together. And obviously the industry is incredibly supportive of the things that are going on, but also what is your sense for how people are feeling about coming back? I know you in the past, at least Jim, you've dealt with a large number of people. I think for you now, John, you have millions of people's lives that you have responsibility for. If you could comment on that, but let's start off with what you guys are working on together, and John, we'll throw it to you.
Yeah, sure. No, really appreciate it. Thrilled to be here, and it's been one of the best parts about having a pandemic, if there can be a best part of any of that, was a chance to broaden relationships. So some of them right here on the line with me today. So I really appreciate it. The thing that is surprising to me, as you said, I've been in healthcare my entire career, vision only really the last several years. And it is probably one of the most collegial industries I've seen. Even competition, very, very collegial. And I think although there's this friction, as you indicate, between managed healthcare, managed vision, and optometry, or the provision of vision services, I find that plays out broadly and in the macro environment, but in the individual one-on-one conversations, hopefully like we're having today, much different story. People really want to serve and care for the patient. So that's why I was thrilled to become part of the project that Jim really led. And really what I found and heard from them is I said, well, what can I provide? What can United Healthcare Vision give? And it was really this feeling of, well, managed care doesn't sit at the table often enough. And I think what people have to realize is, United Healthcare Vision serves 20 million members, commercial, Medicaid, Medicare. We like that diversity. We're the fourth largest. So there is a lot of managed care. I think most of your independent optometrists are probably seeing well over 3/4 of their routine eye exams are probably coming through a managed plan. So right now what's happening is we are working across the industry. We're working with consumers, employers, and providers to try to get things back going. But I do want to share with you what's happening for us is, and I think managed vision care providers need to understand this, and vision providers themselves, especially independents. We have a lot of employers, a lot of small group employers. Right where Eric is probably a classic kind of employer client of ours. They are in jeopardy. It's not a question of, how will I survive? It's a question of if. And though that is a lot of business that comes through their voluntary plan. So when they choose medical and they choose dental and they choose vision, the vision is voluntary. So when we enter a period that's going to be very tight on discretionary income, you have a lot of individuals, whether it's the employer owner, that CEO, who says, I'm not going to provide this coverage because I can't afford it. Or if it's voluntary, that employee may say, I can't do this. It's discretionary. And so I'd really, really encourage people to think about how can we help facilitate that. From an insurance side, we think about that risk all the time. Right now, we're trying to enable it. We're extending the allowance period so people can get their materials since it's been closed for a couple of months. Great question just this past week for those who are aging out at age 26. Can we give them an exception so those adult children who had coverage and lost it during this period, can they get it? For the providers, we really want to support the independents, especially those that serve Medicaid. It's a fragile population I think we as a country have to look at. And as the commercial market may shrink, and it may, between furloughs, layoffs, going out of business, those government roles are going to grow. So what I'm thrilled about is we can really start to talk about the diversity of your practice. And I'm here to tell you that managed vision is going to be in that mix even greater for you. And I think it's a wonderful opportunity. That statistic you just said, Jim, blew my mind. Over 400,000 DREs identifying diabetes that were not identified through a primary care or medical relationship. Optometry, Howard, you know this, 4 years of academia, these are clinicians. I think there's a wonderful opportunity to start talking about moving up to the top of your license. Routine vision and the supply of glasses and contacts, vitally important. But I'm thrilled that maybe we can take this crisis and move into greater provision of actual medical eye care. Look what's happening right outside with Eric. I mean, they're actually practicing primary care medicine and evaluating patients. So really exciting to be parts of groups to do that, and I want to extend those conversations. So that's where our heads are at right now, and happy to give more detail as we go.
Yeah, John, I'd love to give you a little insight as to the patient flow here and the way that this practice has triaged different types of cases to be able to address, optical needs and medical needs in separate parts of the day. And I'd be interested, Jim, to know what you're learning from all of your members about this notion, because the volume, we talked about, Howard asked me at the top of the show, is there this pent-up demand? There is. And there are challenges around actually the physical space to keep patients separate from one another and be able to take as many patients that want to come in, and spacing out those appointments, and then separating those categories of either optical or medical need to different parts of the day so they can address them independently. I don't know what you guys have heard or talked about along those lines, but it's interesting to me because it seems like it's going to be critical for survival. As you mentioned, that this is not a when, but a if. Can we get through this? What are the thoughts around just that bottleneck that's happening here?
Yeah, I think Eric, you're right at the forefront, right? So it's early. If I thought about our conversations with our members, say for the last month and a half, really has been more about, back to not to keep beating the dead horse on survival, but more about survival, managing cash flow, working with our 250 strategic vendor partners to extend terms, allow the doctors to survive through that, help them apply for the CARES Act and PPP. I'd say we're very early, and it's with this recovery reboot program that we're running, along with the other programs that a lot of the great companies in the industry are running, that we're really starting to think this through. And the group that John and I are working together are putting those protocols out there and learning from folks like the ones you're sitting in front of about how to do this. So as you see too, again, I like that jobs and research that comes out each week. As you see, the thing that's trending now is help me figure out how to reopen. And that's the stage we're in. So we're ready to start talking about that now.
Right.
Yeah, that's great. John mentioned earlier collegiality, and I think that has been a wonderful part of this industry. Anybody who comes to this industry sees that. Jim, you and I are probably a good example of that. We work for companies that perhaps were competitive, and yet always managed to work in a professional way in the best interest of our customers, in that case being the ECPs and as well the patients who we serve. But we're going to step away from the collegiality for a moment, because I think there are some tough questions out there that people are asking, and I think it'd be interesting to hear the two of your perspectives on it. And I'll just start with the one that we hear a lot, and especially lately, which is, I want to do everything I can to have no managed vision care plans in my office. They're a pain in the butt. They take too long. I don't make enough money in it. And so I guess my curiosity to you guys is, why do people feel that way? And what would be your response? Maybe we'll start with John. What is it that has created this environment? And it seems to me that perhaps we're in a moment now where we have an opportunity to make some shifts in that relationship, or at least continue building on it. What do you think, John?
Yeah, I hope so. And I believe so as well. And like I told you, I think in the couple of years that I've led our vision program here at United Healthcare, I've seen it. So here's where I think that has come about. First of all, we have together And managed care has its absolute role in this, and responsibility and culpability. But together, we've created complexity on something that shouldn't be this difficult. I tell people when I joined the vision business, I couldn't believe we used the word formulary in contact lenses. Formulary is a bad word in the prescription benefit management world. Why we've imported that word is beyond me. So we could do something simple and we can kill words like formulary. But when the patient comes in, when the member comes in, when the enrollee, it's all the same person, but we call them different things. So we should be caring about the same person. And, thank goodness for your front office staffs, because they have learned every permutation and combination of each managed vision plan's formulary and allowances and when and how it works. So one, we need to work on complexity. This is an amazing mix of medical care and clinical experience and fashion and retail. So it's got a lot that people have to walk through. So I hope through this, we have conversations to get through that. Reimbursement is always going to be there, folks, and we need to talk about that, and we need to work on it, and we need to find reasonable trade-offs. If the routine eye exam doesn't feel like a fair price, well, let's not look at one fee and one fee. Let's look at the basket. And, where Jim and I and others have really started talking is I'd really like to see a greater provision of taking care of that patient. I think post-COVID, independent optometrists especially, because this is their focus. They are business people, but they're clinicians. They have a chance to really move into this medical space as we're talking about. I think we're already having conversations about telehealth coding that should go, that I think can be a lot quicker and easier for looking at some basic things. We are investing in relationships around artificial intelligence, diabetic retinopathy, through a company called IDX. We're looking at partnership with a host of organizations to do more medical care, including nothing related to the eye. So we have encouraged an adversarial relationship around fees, but I don't think we've ever created an adversarial relationship about how to take care of that patient. I'll tell you, we have the statistics pre-COVID is 26,000 calls were coming into United Healthcare every week. My competitors have probably more. That call volume is down to 6,700, okay? Here's the interesting thing, it's starting to creep up, but it's creeping up on the member or the patient side. It's not creeping up on the provider. Providers were calling us about 6,700 times a month as well. They're down to 1,800. We're not seeing the uptick yet. Patients are going to call us because they're going to want to know the place that Eric is at right now, the large box retailer, the Warbies, are they open? So they will probably call us. You may not feel that, but there is some trust there. We need to know if you're open. We need you to be out there marketing to really get, keep and gain market share for your patients. The other thing is they're going to want to know, are you safe? So that's where I think we can work together. So let's work on complexity. We're always going to have the reimbursement conversation, and you have my word, at least from United Healthcare Vision, that'll be a transparent and upfront conversation where we feel we all can win. And I'd love us to see taking better medical care of that patient. So look, folks, we're here. We're not going to go away. In fact, I think, and that's not a threat, that's just, I think, a good reality statement. And I think what you have to realize is if the commercial market comes under pressure, you're going to see more people opting into exchanges. You're going to see much more people going into Medicaid as kind of the means testing of that continues to increase or evolve. And that is a space that governments look to health plans to really help them manage the costs and really facilitate the member experience. So if we don't work together, I don't think we're going to really make the best decisions for the patients together. So
John,
those are some thoughts.
I would love to follow up on something that you said about letting the patient base know that you're open if and when you are, especially well in advance. What I'm learning from a lot of the optometrists that I'm speaking with out here in the field is that prior communication between the patient and the practice is everything. Because if the patient knows they're open and for what services and what are the conditions going to be when they come to the office, that's what they want to know in advance. Do they need to wear a mask? I mean, there's like a list of details that are really critical. Do they need to wear a mask? Can they bring someone with them? Can they bring a caregiver? Can they bring a family member? Will they be safe, and what precautions are going to be taken? So some of these practitioners have taken to producing videos and pushing them out to the patient base that illustrates all of those points. That everything's being cleaned, masks are being worn. In many cases, like at this practice, they'll supply you with a mask if you don't have one. You must have one to come in, and not necessarily under state or county guidelines, but under the policy of the practice, which I think most practices are undertaking a mask policy here. And the patients want to know overwhelmingly, are the frames clean to touch? You have hundreds of pieces of eyewear along the walls in these places, and they're taking great pains to clean everything here constantly. So there's a huge time function that goes along with the preparation here. But to your point, the communication with the patient in advance is what I'm hearing to be the saving grace of people willing to come into the practice.
I've even seen some who have developed some nice videos that they can show to their patients and send to their patients so they see the painstaking efforts in many cases that they're going through. John, just a quick follow-up I had for you as well. You mentioned something that is very interesting to me. Well, many things that was very interesting, but one in particular that I was going to ask you about. If practitioners are open, should they be informing their healthcare providers, their vision care plans, that they are actually open for business? You suggested that many patients will be calling these providers like United Healthcare. Is there a way for you guys to know? Is there something the practitioner should do in order to let you know they are open for business?
Yeah, I think they should. I will tell you, it's probably going to vary by managed vision plan in terms of how they're going to capture that information. But it's one of those things where it won't hurt. Big box retailers and the retail, part of the vision and optical industry, they're telling us. They're telling us how they are moving, slowly or testing. And thank goodness they're doing that in terms of opening. And I think they're doing a wonderful job. So yes, it will not hurt. B, we will, with a member on the line, call a clinic or an optical office to see if in fact it's open. So there's no harm done. But what Eric just said is the best. Boy, be proactive. My barber, and though you can't really tell, my barber has already reached out to me via email and told me, when he's going to be open and what he's going to do. Boy, my PCP hasn't called me, and my eye doctor, well, he's a friend, so I know. I see him walking around.
It's a good message. I think my wife is ready to call my barber and ask him if he's available. Jim, we didn't let you weigh in on this, and you spent a good deal of your career at VSP in addition to the wonderful things you're doing at HEA now. And I just want you to weigh in on that subject because I know it weighs on everybody's mind on both sides of this, is this feeling as I have to get rid of healthcare plans, vision care plans. They're bad for me. I don't get reimbursed. And I thought John did a nice job of explaining that he continues to review those things. But you've sat in that chair before too. And what might you say? How would you respond to that, particularly at this point in time as we go through this significant transition that is not likely to be over very soon?
Sure, absolutely, Howard. That rallying cry is not new. It's been around for a long time. Heard it during my time when I was at VSP. The real issue, and you guys both touched on it, right? 75% of all the eye exams performed in the United States have some form of managed vision care associated with it. So it's not that easy to get rid of them, especially in certain states. In my opinion, I pretty much, I'm the recovering managed vision care guy, right? John's in the thick, so I defer to him. But, I think the better idea is for the IECPs or the ECPs and the managed vision care companies to work together to improve the patient and consumer experience. John hit it on the head, right? It's much too complicated. It lacks transparency. Consumers walk into the practice, they don't have an understanding of their benefits. It causes a friction between the practice and the consumer. And then also, I believe a lot of practices don't fully understand the benefit and how to leverage the different offerings in there and what products they should have in their practice to take advantage of their managed vision care patients, so that when they fully understand it, they can provide them the solutions that they need. I really believe with technology, and this builds on what Eric said, this idea of patient engagement has always been important. And in patient engagement before they come into the office, I think it's going to become even more important going forward. If I'm a patient, I'm going to ask, how can I spend the minimal amount of time in the office? So I want to come in armed with knowing what my benefit is, what's covered, what's not. I want to know that maybe I selected my frames before they came in and they're already there waiting for me, and I know they're in this nice clean case, so I'm feeling comfortable. It's all about improving that transparency. And I think we were together, Howard, at an innovation summit where we talked about that whole process of buying eyewear today. Way too complicated, lacks transparency. And what we really need to do is to get these two groups together, the ECPs, the managed vision care companies, and work together for the good. As John said, we refer to them as many different things. The members to the vision care companies, the patient to the doctor, and then really what they are is consumers, right? And we really need to do that during these difficult times. So I think it's more about working together and solving the problems at hand than just saying, I'm going to do without it, because they do provide those eye exams and provide those bodies coming in the door, and we need to figure out what to do with them within the practices.
We need to learn how to coexist together, and I think that's it. I just think sometimes my colleagues feel like they don't have that voice, and where can they go for that voice? And I love that you two are working on, along with, you mentioned Vision Council and a couple others, some projects to help support some of those efforts. I think people just want to be heard. They want to have a voice, and they get frustrated, as we all do at times. And people like the two of you who are open enough and transparent enough to provide those type of opportunities, and people need to take advantage of it. I know a lot of times the sentiment is, oh, I'm just one person, I called there, nobody really cares. But I've sat in the seats where you guys do, or similar seats, and I know that so few people do take the time to give that feedback, that when people do, we listen. People like you two guys listen. And I think people need to know that, even though you're one small practice somewhere, perhaps it's important because you get such little feedback directly like that, and you're hungry for it in many cases. So yeah, thank you, Jim. That's really good insights. And John, you had mentioned earlier something about artificial intelligence and telehealth, perhaps along with that. I'm wondering if you could give us a little perspective with regard to how United Health is looking at it. I think we're all embracing telehealth a lot more than we ever did before. Certainly at the college, we have done a lot in the area of telehealth. We didn't want to abandon our patients at the height of what was going on, and it was a great resource. But I think people would be interested in knowing how a group like United Health is looking at technologies like artificial intelligence and telehealth as we move forward.
Sure. Yeah, no, happy to. And I think we all agree, if we were wondering if telehealth and telemedicine was going to take hold and stay, we no longer have to ask that question. I mean, you've seen countries embrace. The UK said, yep, get on FaceTime and have a visit with your doctor. So, whatever cliche you want to use, the genie is out of the bottle. It is not going back. So if any viewers think this is still maybe, they should rethink that. United Healthcare and United Health Group has obviously a lot of business that even goes outside of vision. So we've looked at this and embraced it and partnered. So behavioral health telemedicine is phenomenal, and thank goodness we have it, because there's a dearth of providers we need, especially now. Pharmacy consults. So it is everywhere, and I think for vision, I still think we have opportunities to really maximize it. Dr. Scott Edmonds, who's our chief eye care officer and a practicing clinician with his wife and his sons in Pennsylvania, told me they quickly told their clients for contact renewals, they can do that right on the phone. So I'm seeing some really kind of cool grassroots things of providers do it. Let's quickly kind of get together, and I think NAVCP is a phenomenal place to do this, and it does have it as a focus, and we want to work collaboratively with all the right constituents. But I think we need to take it further than just, hey, can I have a consult on the phone? And we have to continue to watch the technology. I think we're far, we're not yet there. I won't put a time frame on it from when you can maybe do an online refraction. I get that. But there are absolute opportunities, and United Health Group invests in companies. As you know, we're a care provider. We were actually on the front end of COVID out in Everett, Washington, with some of the provider-owned clinics that we manage and own. But even in the technology space, so we are looking at and investing in those who are getting into, if it's not telemedicine, it's also artificial intelligence. So I just briefly mentioned one, IDX. It's FDA approved, and it's utilizing an Optus camera, can take a picture of the eye, and through the algorithm that they have built, which is phenomenal and fascinating, it can tell you without human intervention, do you have diabetic retinopathy, yes or no? And so, right to Jim's point, there are going to be modalities that, as long as we all feel comfortable with them and they're approved and clinically effective, that the consumer is probably going to like, because it's going to shorten their experience. They're going to get in and out. It's going to be less touch. So this is an area where we as an organization, United Healthcare and Group, that we focus on, we invest in, we look at those technologies. I think vision has the opportunity to accelerate very quickly. I am looking for those partners who want to try those things, and I'm also looking for that consensus to be built. So heavily relying on clinicians to kind of tell us, but I'm reminded, and I'll kind of end with this, it's the vision industry's kind of anecdote, not mine, where when the autorefractor came out, we all thought we were going to go out of business. I kind of feel like we need to think the same way about new technologies. It is going to enhance your business and allow you to do even more in the medical space.
Well said. Well said. Eric, how's it going out there? You seeing some traffic out in the office? What's happening out there?
There is some traffic. I think I might have mentioned before, there are 34 to 35 appointments booked here today. And I've seen, well, what do we have here? We have 5 cars in the parking lot, and what's happening right now, you see the tent over my shoulder. Staff will wait there, and they will wave to the individual cars and say, okay, come over here. And they come over, they get their temperature taken on their forehead, and then they're cleared to go inside. So yeah, we expect the patient to continue.
Masks are required by the patients. They have to bring their own masks, or they're providing masks, or how is that working?
Most patients that are showing up here are wearing masks because they know in advance, to our conversation before about the prior communication. So this practice has done an incredible job on many fronts with informing the patient about the policies and how this will look. So nobody's surprised when they come around and see a sign on the other side of this building that says, pull around to the back, park over here and wait. They're already aware of the whole process. So they're not coming here and getting out of their cars and approaching the doors or going into the front door where they normally would. This is a set up area that is the screening zone. I mean, and this is something that nobody's ever seen before. I mean, to approach a medical practice in this way and be screened like almost like you're getting on an airplane, but not for security, but just for the simple fact of the temperature of your body. Whoever thought, that we'd be doing this, and the adaptation process that I'm learning here is incredible. I mean, this practice has been in business for 40 years and has a huge base here. This is a county of 19,000 people. The COVID presence here is low relative to other places. So, even if people are in areas of the country where they think the disease is not, it doesn't seem like it matters. This is 19,000 population in the county. They've had 160 cases and only 4 deaths. And throughout most of this area, people are behaving normally, going about their lives now within the last week or so. As Georgia has opened up early, that's why I'm here to see this large, substantial practice that's serving this big rural area for a long time. If anybody can reopen and do a great job, it's going to be a practice like this with a strong base. And to see that they're down 75% right now in terms of patient flow, and hoping to get up to maybe 50% and 80%, they seem to know that 1 in 4 or 25% of the patients are really afraid. Like people that would come in but don't. But then there are people who want to come here just to get out of the house and buy some glasses. So you have just a huge variety of patient attitude, and all of that is being addressed by this team here that is being so proactive in communicating with the patient base, so that they, in their own self-preservation, they need to do that, because otherwise they just don't have a workflow here. So I think what practices can learn, and you guys will see this in my report tonight, because I'm going to package up everything that I've learned here as an example for some of the things that practices will face. It's a wide variety of staffing issues, time management, space management, and communication with the patient.
Well, thank you. Thank you for being out there, Eric. We appreciate it. Yeah, I mean, it sounds to me like, doing the pre-work, getting some information to the patients before they come to the office seems like a critical component to making this work, and sounds like this practice has done a good job of doing that. So as we start to wind down here, go ahead, please.
Yeah. Well, the tent, you might wonder why the tent. And, many places will be checking in people outside, but like the operations manager here told me yesterday, you would think that a tent is not a big thing, but it's protecting from the heat because it's been 90 degrees here. So, you're addressing your entire area in how do you manage the workflow under these different constraints.
Wow, they've done a nice job. What's the name of that practice that you're at? Do you know?
This is Wilson Eye Care in Valdosta, Georgia.
We thank Wilson Eye Care
Wilson Eye Center, yes.
Wilson Eye Center for letting you loiter in their parking lot there. I hope those guys are okay with that. No, but thank you for bringing us a view of what it's really looking like out there, Eric. We appreciate it.
It's been great. And in the report tonight, you'll see that. And they've really got a great example of what to expect.
Wonderful. Hey, Jim, we're going to throw it to you for a minute. First of all, any questions or any comments you wanted to make with regard to artificial intelligence or telemedicine, telehealth? We'd love to hear from you on that. And then you did already share with us a book that you like, but any suggestions on references or things you're reading that you have already helped us with the team of teams sounded very interesting. But perhaps you can help us with a couple of those thoughts as we start to wind down.
Sure, Howard. You know, it's interesting as I'm sitting through the discussion. I realize I'm a recovering bunch of things. I'm a recovering managed vision care guy. I'm also a recovering IT guy. You know, I came into the industry as, you know, Marchand's CIO, and that's how I got introduced 20 years ago. So technology to me, and really technology being used to enable businesses, has been a passion of mine throughout my career. I believe, you know, the technology is the future. As John said, the technology is not the enemy. How do we leverage these technologies to make our practices better and more efficient? And, you know, as we're learning from the consumers as they're going through this process, and Eric's right there on the front line, what do we learn? And I think we will learn. They want to spend less time in the office. So how are we going to do that? Fill out all your forms before you go in. As much screening that can be done before I get in the office. As I can try, if I can try on my frames, if I can also have a discussion about what lenses might be good for me, all before I walk in the door, it can limit the amount of time I have to be in there. And then it also will allow the doctor to increase patient flow. Because right now they have this setup or this cadence where, you know, the person in the car and then go in, and they end up spending a longer period of time. But with these technologies, whether it's AI based or not, we're going to be able to streamline that process. So I think that's really the way we should be looking at it. And I do think crises like this will increase the intensity and the focus on these technologies like telehealth and telemedicine, and how to best leverage them, always with the good of the patient in mind, right? So a comprehensive eye exam is still critical, right? Without a comprehensive eye exam, those 401,000 diabetics would not have been uncovered. So we need to make sure the technology supports that part of the business. Beyond that, you know, I mentioned the Team of Teams book. You know, another guy I'm a huge fan of is this guy, Patrick Lencioni. He wrote books like 5 Dysfunctions of a Team, Death by Meetings. He just has a really good way about him, has a lot of great insights and videos out there to help you, help you learn and get focused. And I think, the work that we've done in this recovery reboot, as well as this Team of Teams work that we're doing with John and the other CEOs in the industry, not out there yet. Hopefully by the end of the week, we can announce and get it out. And hopefully that will be a very focused and provide the guidelines and checklists needed to help through this process. But it's like you said, it's a cliche, but we'll get through it together. We'll get through it as a team of teams, and then we'll get this industry thriving as quickly as we can.
Well, thank you, Jim, very much. First of all, thank you for being on the show, and thank you for all the great work you guys are doing at HEA. We welcome you to come back anytime or provide us with information on the progress you guys are making. We certainly want to make sure that people are listening into InsideVision are as up to date as possible. And thank you for everything Howard, you continue to do.
Just one other thing. I'm sorry.
Please.
There's just again, because doctors have been so consumed with everything that they're doing to get their practices open, just wanted to make everyone aware we have a 8 hours of continuing education available to HEA members and non-members a week from Sunday, and it's all done online. So if a doctor's been putting that off or been working on it, it's available to them. It's our ocular symposium that we typically run 3 times in California, face to face, but it's going to be delivered online, and COPE has approved it. So for doctors that need to get that caught up, it's there and it's available to them.
Thank you. And thank you again, as I said, for all the things you continue to do for the industry. You've done it all your career. We don't expect anything different from you. And good luck to HEA as it continues to grow and serve the community. We appreciate it. So, John, we're going to let you have the last word before we kick it back to Eric. And just first of all, I want to say thank you. I know you got a lot going on over there at the moment with all like we do and everybody trying to come back and make their way back. So any final thoughts you would have, and we'd love for you to share anything that you've been looking at, reading, references that you think would be helpful to people as we all try to do our best to navigate through and hopefully managed care will help to rescue the ECP. So we'll give you the last word, John.
Well, that's dangerous, but I greatly appreciate it. First thing I want to do is I want to thank the independent ECPs. I want to thank our entire network. During this time, they have maximized it. We've gotten credentialing cleaned up. We've gotten kind of past receivables cleaned up, and if we have some work to do with you or you're having some challenges, please, our lines are open. We're an essential business. We have never closed. We have people answering the phones. So, United Healthcare Vision Spectera, if we can help you, please let us know. When I think about kind of what I'm reading or what's impactful, Team of Teams is phenomenal. We've already talked about that. I think it's a great way to look at it. Another book about change that I think is simple and so works for me, a business book that's straightforward, Leading Change by John Kotter, Harvard business professor. Probably one of the best books. I've used it several times around creating wholesale, large organizational change. I think it's very applicable to really any size. So that's one I'd recommend. The other one is we've talked about the kind of consumer and the retailization that's existed for a long, long time in this business. People probably need to start thinking about the mind of the consumer. And a great one that's kind of fun, a little different, Dan Ariely, a Duke professor, I believe. He has Predictably Irrational. I've seen him speak, I've had him part of our meetings, and he gives you a really good mind about how consumers and people don't always choose the most rational thing. And I think in the current phase we're in and what we go to, that may be really telling. And the last thing I'll tell you is I'm the son of an English professor. So maybe it's also time to read the novel you've put off or reread the novel that you love, because I'll tell you, a little escapism is not bad. I'm week 7 in my basement here. I think they're going to let me out. So thanks so much for the time, and thanks for the collegiality.
No, thank you, John. Thank you for everything you're doing at United Healthcare. We're glad you're there. We're glad you're on that wall watching our back. We appreciate it, and appreciate the openness and transparency that you've tried to operate with, and your openness to hearing from my colleagues about challenges, opportunities, and successes that they're having with the group. So thank you very much for that. Before I throw it, Eric, I do want to remind you that next Wednesday, 9:30 a.m., we'll be focusing very specifically on the return back. And Eric and I wanted to solicit from you, if you have a short video you wouldn't mind sharing with us to give us a look at what you're doing in your office. We'd like to show it during the show at some point in time. I think your colleagues would love to see what it is you're doing right now to try to prepare and make patients feel as comfortable as they possibly can with what's going on in your office. So lots of places you can send it, but I'll give you my email address. It's purcellh, Purcellh, at neco.edu. If you want to send that short video to me or to Eric, we welcome you to send it. He'll give you his information in a moment. But before I throw it to him to sort of close things off, I want to once again thank Jim McGran, John Ryan, two quality, classy gentlemen who are running very important organizations in our industry. And these are people who really care about the industry. And those are the people you want to partner with. So I thank them very much for their candor, their honesty today. Look forward to welcoming them back. And with that, Eric, I'm going to kick it back to you for a few final words and then a little bit of something to think about.
Yeah, something to think about is coming up. But first and foremost, I want to thank the staff here at Wilson Eye Center in Valdosta, Georgia, for showing me what it can be like to come back with an optometric practice amidst this unbelievable set of circumstances. And again, I will really want to promote my report tonight, where I'll be showing what they've been facing, how they've been handling it, and it'll be a guideline for so many practices. I really think it's going to be valuable. So if you haven't subscribed to the YouTube channel, hit subscribe now and you will get a notification as to when that report's available. So more on that later, and for now, we'll look forward to next week and give you something to think about.
Thank you, Eric. As many of you are facing reopening or resuming practice, there's going to be a number of different challenges for all of us as we enter this new phase of the new normal. Some things have definitely changed about what you're going to encounter. Reduced volumes of patients, taking more time between your examinations, spacing your patients out to preserve the safety for your staff and your patients alike. That's going to affect certain practice metrics that we've become familiar with over the years, primarily practice profitability, because certain things haven't changed, and that's your cost structure. So it's very important for you to be aware of what your chair cost is. Now, that may be a term that's familiar from optometry school, and if you haven't calculated your chair cost or are unfamiliar with it and need some help, email me at the email address in the lower right-hand corner, and I'll be happy to help. Knowing your chair cost is vitally important to understanding your profitability per service performed. So if you're evaluating what services you're going to perform, routine care under a managed vision care plan that used to be palatable, but maybe today isn't because of the reduced compensation and the reduced volume, or if you're switching to medical care primarily because you think it's going to pay more, understanding your profitability per minute is important. And that's exactly what share costs can help you with. But don't make those decisions lightly if you're going to make a decision to quit a plan, whether it be medical or managed vision care. Follow the provisions in your contract to the letter, because sometimes plans won't let you back in if you've quit them. The other thing that's vitally important is that many plans require you to provide run-out care for a period of time after the contract's been terminated. So getting rid of them is not always that easy. Make these decisions wisely, do your math, understand your numbers, and that's something to think about.
Thanks for watching Inside Vision. To receive updates about our programming, click subscribe.